This is EHJ Today at the Annual Congress of the European Society of Cardiology in Rome 2016. I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm talking to I.K. Cheng from the Massachusetts General Hospital, and he's Professor of Medicine at Harvard Medical School, and to Peter Libby, who is the Mallinckrodt Professor at Harvard and cardiologist at the Brigham and Women's Hospital. Welcome, gentlemen. So we're discussing the erosion study, and what's the objective? What was the objective of the erosion study?
So if I may give you a little bit of background. So there are three underlying pathologies for sudden cardiac death: acute coronary syndrome, including acute MI, plaque rupture, erosion, and calcified nodule. Plaque rupture has been well characterized both ex vivo and in vivo. Plaque erosion has well known for pathologists, but it was not possible to make diagnosis of plaque erosion. With the introduction of optical coherence tomography, we thought we might be able to make an in vivo diagnosis of erosion. So in collaboration with Dr. Renu Virmani, we have established algorithm to make OCT diagnosis of erosion. And 3 years ago, we reported in patients with ACS that erosion was responsible in 1/3 of the patients. Yes. And subsequently, different set of patients, all with STEMI, we again reported erosion was the underlying mechanism in 1 out of 4. Yes. So in this erosion study, we prospectively look at the prevalence of erosion, right, but also erosion, what we learned from previous 2 studies and also from pathology studies, has distinctly different morphologic characteristics compared to rupture. Also pathology. Yeah. So compared to rupture, erosion, vascular integrity is better preserved. Lumens larger, and platelet-rich thrombus appears to be more frequent. Yes. So if you think about it, vessel is in much better shape. So if you treat platelets effectively, you may be able to stabilize the condition without putting a stent, right, and thereby avoid stent-related late and acute complications. So we wanted to test this hypothesis that we can stabilize this. So we, in this study, included 405 patients who underwent emergency catheterization for ACS. Among them, 103 was found to have erosion.
So these are STEMIs only?
No, it's the ACS patient. The study was designed and analysis was done in Boston, but study itself was done in China. So vast majority of patients had STEMI.
Yes. Okay. So about more than half?
Oh, over 90%.
Over 90%, okay. Yes, which is unusual in our part of the world. We have about 40% STEMIs, and in some centers, depending on the referral, even less. Yes, exactly. Good. So what did you find? So
the primary endpoint was more than 50% reduction in thrombus volume, which we can measure with OCT. So 6 patients were included in the final analysis. 1 patient died, and the other patient had other issues. So 55 patients came back for repeat OCT after 1 month treatment with antiplatelet therapy. Only 55. Yeah.
No, I mean,
in addition to statin, beta blocker.
Right, exactly, but without a stent.
Without stent. So this was sort of proof of concept pilot study, just to look at the feasibility. So if you use intention to treat analysis, 78% of the patients met the primary endpoint. And if you really look at only 55 patients who had a repeat OCT, 85% of the patients met the primary endpoint, more than 50% reduction. 22 patients had 0 residual thrombus, and with significant increase in minimal flow area.
Yes. All right. That's very interesting, very thought-provoking results. What do you think, Peter, about it?
Well, I think this is an enormous step forward. in thinking about personalized medicine, which is our injunction these days. We tend to treat the ACS as a one-size-fits-all undertaking, or we stratify them based on the appearance of the cardiogram. But here we're being driven by biology. And in my laboratory work, I've always tried to inspire myself from the clinical experience, my own, and then others. And I say that IK's work has been inspiring me for quite a while, as well as Renu Virmani's. And I think that it's high time that we begin to ask the question of whether different pathophysiologic mechanisms that trigger an ACS might merit a different kind of treatment. ST up, ST down, that doesn't tell us what's happening at the level of the artery wall. So I think that this is a very important study. This is the largest study that's looked at this. And I think that it's high time for a randomized kind of trial. A little hard to design with a blind if we're going to be comparing stenting versus non-stenting. But I think that you guys are real good at designing these studies, and I think we need to move forward in this direction. I have a couple of questions, and IK, when you came to give Grand Rounds, I was asking these kinds of questions, so this will be no surprise. But, from the pathological studies where you have to die to get in them, the proposition of Renu Virmani and others is that this is a more common presentation in women. And I guess some recent Australian experience from Steve Nichols' group suggests that that is the case, but I think you might have a different point of view.
Yes. So by now we have a database of 600 patients. Right now we are looking at any predictors for plaque erosion, demographics, angio. We did not find gender difference.
What is a predictor then?
We are analyzing at the present time.
Yeah. But I have a question. When you have a STEMI, let's say, you place the wire anyway, otherwise you cannot do OCT. Are you then ballooning at the site of occlusion?
We avoid balloon, but we did aspiration manual thrombectomy.
Right. So you do thrombectomy first, and then you look at it with OCT, and then you also decide based on the diameter whether to stent or not to stent?
Instead of diameter, we had an inclusion criteria, angiographic stenosis should be less than 70%.
Well, with OCT you can precisely measure that, so it's not eyeballing, and so...
That would have been much better. We are now analyzing retrospectively. Right.
Well, good. I think that's a very exciting new avenue. And so what trial would you design, Peter?
Well, I still have a couple questions for IK. One of which is, I read the Jha paper, your previous paper, very carefully, and I've actually plotted some of the data about OCT versus rupture and STEMI versus non-STEMI, and the numbers are small, but I've gone around the world showing your data with the hypothesis that erosion is more likely associated with non-STEMI than STEMI. Exactly. And is that holding up?
Yes, so far.
That's great. And I also asked you once before, we think that flow disturbances are important in some of the endothelial perturbations, and maybe distal to a culprit or distal to a tight stenosis, the MLD, the minimum luminal diameter, you might have flow disturbance and might have more erosion. And so I'd asked you whether it's more common to be distal to a flow limiting lesion. And I think your answer informed me.
Yes. Currently we are analyzing in collaboration with Dr. Levy's group, Peter Stone, the detailed endothelial shear stress in relation to erosion and the place of thrombus.
Right. Well, these are very exciting avenues, and I think we should really pursue that all. And many of us do OCT, and we should. It makes everything more interesting, I think, because it's not a very simple no-brainer approach, and that we're very much looking forward to the development of this field.
It's not just more interesting. I think that we may have a way of really tailoring therapy based on pathophysiology.
Right. More precision medicine.
So I think the field owes you a vote of thanks for having pursued this. Right. It's not an easy study.
Well, thank you very much for joining us. Thank you.